The medical world calls the midurethral sling the absolute, gold standard for treating stress urinary incontinence.
Ah.
But, and this is a big but, what happens when that gold standard fails 1 in 5 women who get it?
Right. It forces a complete paradigm shift. I mean, for both the surgeon and the patient, you go from a relatively straightforward, highly protocolized primary procedure into, well, a really unpredictable landscape.
Because a failure rate of 5 to 20%, that's a massive clinical burden, right? Especially given how incredibly common this operation is globally.
Oh, absolutely. It's a huge volume of patients dealing with this.
So today's deep dive is geared specifically toward navigating that exact aftermath. If you are looking at the realities of a failed first-line sling, we are doing a deep dive into the diagnostic detective work required to figure out your next move.
Yeah, we're looking at the biomechanics of the surgical menu and, the complex reality of how a previous failed sling completely dictates the approach to any revision procedure.
Exactly. And I think the central premise we really have to establish right up front is that there is no singular best second-line treatment.
No, definitely not. When you're dealing with a revision, you just cannot apply a blanket fix. The surgical approach is entirely dependent on the specific mechanism of why that primary one failed.
Right. And I want to look at how we even define failure in this context, because it seems like the immediate assumption for most people is just, well, persistent leakage.
Right, like, I had the surgery to stop leaking, I am still leaking, so it failed.
Exactly. But it's more than that, isn't it?
Yeah, it is. I mean, persistent or recurrent leakage is certainly the most common metric of failure, but the clinical definition is actually a much wider umbrella.
What else does it cover?
Well, a midurethral sling is also considered a failure if it requires secondary surgical intervention due to synthetic mesh exposure.
Wait, like where the plastic actually erodes through the vaginal wall?
Yes, exactly. It literally pokes through.
Huh.
And it also includes cases of severe post-operative urinary retention, meaning the patient can, no longer empty their bladder effectively.
Oh, wow. So the opposite problem.
Right? And it also covers de novo urgency, so brand new, severe urge incontinence that wasn't even there before, and cases of debilitating chronic pelvic pain caused by the mesh or how it was tensioned.
So rather than looking at this like a car's check engine light coming on, this feels much more like structural engineering.
Structural engineering, how so? Like if you build a suspension bridge and it fails, it might be because the cables snapped under too much weight, or maybe the concrete anchors eroded, or, I don't know, the wind dynamics were totally miscalculated.
Oh, I see what you mean.
The bridge failed in all those scenarios,
Mm.
but how you rebuild it changes drastically based on which component actually gave way.
That structural metaphor maps perfectly onto the pelvic floor, actually. And before a surgeon even considers how to rebuild that support structure, they have to analyze the physiological load that caused the breakdown in the first place. Right? What was the pressure on the system?
Exactly. And the multivariate analysis data reveals very specific independent predictors for why a primary sling is more likely to fail. For instance, a body mass index over 25 carries an odds ratio of 2.9 for sling failure.
Nearly 3 times the risk. Which, biologically, that makes sense if we stick to the structural engineering idea.
Right. It's just pure physics at that point.
Because higher BMI translates directly to increased intra-abdominal pressure. Every time there's a cough, a laugh, or physical exertion, the downward mechanical force on the pelvic floor is just exponentially higher.
You're hitting on the exact biomechanical mechanism. It's a constant battle against physics. That constant stress could stretch the nascent scar tissue before it has a chance to, fully integrate with the pores of the synthetic mesh.
So the bridge just gives out before the concrete dries, basically.
Basically, yeah. Then we look at mixed urinary incontinence, which carries an odds ratio of 2.4.
Mixed incontinence. That's when there is both stress incontinence from physical pressure and urge incontinence, which is more of a neurological bladder spasm, right?
Correct. And when you have mixed incontinence, the sling is only designed to fix the mechanical stress component. It does absolutely nothing for the neurological urgency.
So the bladder is still spasming.
Right. If the detrusor muscle of the bladder is spasming on its own, the mechanical backboard of a sling won't stop that pressure wave. So the patient perceives the surgery as a failure, even if the sling is structurally sound.
That makes a lot of sense. The data also showed a prior continence surgery bumps the odds ratio to 2.2, and I saw diabetes sitting at a 1.8 odds ratio for failure.
Yes, diabetes is a big factor.
I assume that comes down to, microvascular complications affecting how the tissue actually heals around the mesh.
You nailed it. Poor tissue perfusion is the primary culprit there. For a synthetic sling to hold, the body's macrophages and fibroblasts have to infiltrate the mesh and create a robust integrated scar plate.
And diabetes impairs that.
Exactly. It impairs that microvascular response, leading to weak integration or, even worse, tissue necrosis that just paves the way for mesh erosion.
Ugh, wow.
Yeah. And we see a similar mechanical risk tied to the surgical technique itself. A vaginal incision length of greater than 2 centimeters during the initial surgery significantly portends an increased risk of mesh erosion down the road.
Because a larger incision creates a larger avascular plane, right?
Right.
You are disrupting more of the local blood supply to the vaginal epithelium, which means the tissue covering the mesh is thinner and just, more vulnerable to breaking down over time.
That is the exact pathophysiology. The larger the disruption of the vascular bed, the higher the likelihood that the synthetic material eventually pokes through.
Okay, so if the risk factors create this massive matrix of potential physiological failures, the diagnostic phase before a revision surgery must be incredibly rigorous.
Oh, it has to be. You can't just jump in.
You aren't just taking the patient's word that they are leaking, you have to map the exact structural deficit. What does that detective work look like?
The clinical workup for a revision is exhaustive. It goes way beyond the standard voiding diaries and 24-hour pad tests that we just use to quantify the volume of the leak.
Right, because you need to see what's happening inside.
Exactly. In the context of a failed prior surgery, imaging is critical. Surgeons utilize transperineal ultrasound to visualize the post-operative changes in the pelvic floor anatomy in real time.
So they can watch what happens when the patient actually coughs or bears down.
Yes, they need to see exactly where that first sling is sitting dynamically under pressure.
And you also have to rule out whether the original mesh has migrated somewhere it shouldn't be, right?
Right.
Which is why a cystoscopy is mandatory.
Right. A cystoscopy is non-negotiable. You need a camera inside the urethra and bladder to guarantee a piece of plastic hasn't eroded into the lower urinary tract itself.
Because if it has, that changes everything.
Completely. But, the most vital diagnostic tool, and arguably the one that dictates the revision strategy the absolute most, is urodynamic testing.
Now, I always wrestle with the clinical necessity of urodynamics for a patient who is clearly experiencing stress incontinence.
How do you mean?
Well, if someone is standing in the clinic and leaks visibly during a cough test, why put them through an invasive procedure with catheters to measure bladder pressures?
Yeah.
Like the physical evidence of the leak is right there in front of you.
I get that. But the physical evidence tells you that the bridge fell down. Urodynamics tell you which specific component failed.
Oh, okay.
And in pelvic floor medicine, we are primarily trying to distinguish between two distinct mechanisms of stress leakage: a hypermobile urethra and intrinsic sphincter deficiency, or ISD.
Let's visualize that for a second. If we picture the urethra as a garden hose,
Sure, great analogy.
hypermobility means the tissues surrounding the hose are lax. When intra-abdominal pressure hits, the hose gets pushed downward and sort of flops around because it lacks a firm backboard to compress against.
Yes, the valve inside the hose still works fine, but the structure supporting it is just too weak to keep it stable under pressure.
And a standard sling fixes hypermobility by acting as a rigid backboard behind the hose.
Precisely. It gives the hose something to squeeze against.
But ISD, intrinsic sphincter deficiency, means the internal valve of the hose is physically degraded.
Right.
The hose might be perfectly stable and tied down, but the nozzle is stripped. It's a fixed, incompetent tube.
Exactly. And that distinction changes everything about the surgical menu. Everything.
Why is that?
Because if you have ISD, the pressure dynamics inside the urethra are fundamentally altered. If a surgeon just throws another standard midurethral sling at a patient with ISD without knowing the sphincter is internally deficient,
The revision is highly likely to fail again.
highly likely, almost a guarantee.
Okay, so you've mapped the anatomy, you've run the urodynamics, and visualized the original mesh. Now you have to match the mechanism of the failure to the revision surgery.
Yes, matching the fix to the flaw.
Looking at the data for a repeat midurethral sling, the efficacy drops substantially. Like, a primary sling has an 86% subjective cure rate, but a repeat synthetic sling drops down to 62%.
It does. The odds of success decrease significantly the second time around, largely due to the scar tissue from the first surgery altering the tissue planes and the flexibility of the area.
Which makes placing it much harder.
Exactly. And this is exactly where those urodynamic results dictate the surgical route. There are two primary trajectories: for placing a sling.
Right, the transobturator approach, which runs horizontally out through the groin, and the retropubic approach, which pulls upward behind the pubic bone.
You've got it.
If we think about the biomechanics, the retropubic route creates a tight U shape around the urethra, while the transobturator route creates more of a, like a flat hammock.
Yes, a much shallower angle.
So if a patient has ISD, that broken internal nozzle, the flatter transobturator hammock won't provide enough compressive force to close the valve.
You've nailed the biomechanics. The clinical data strongly supports that logic, too. For repeat slings, the retropubic approach yields a 71% success rate compared to just 48% for the transobturator approach.
Wow, that is a huge difference, 71 versus 48?
It is. The retropubic trajectory provides a much sharper angle of tension and greater urethral coaptation, which is absolutely vital if you are trying to compensate for an incompetent internal sphincter.
Right. But that assumes the patient is willing to have another piece of synthetic plastic implanted.
Ah, yes. The mesh dilemma.
Because if a patient is dealing with mesh erosion or chronic pain from that first synthetic sling, they are likely going to demand a revision that avoids synthetic materials entirely.
And understandably so. That pivots the surgical plan to an autologous pubovaginal sling, or PVS.
Autologous signifies utilizing the patient's native tissue.
Correct. The surgeon harvests a strip of strong connective fascia, typically from the rectus muscle in the abdomen or the fascia lata in the thigh, and utilizes that native tissue to create the supportive hammock.
But harvesting native fascia turns a minimally invasive vaginal procedure into a much more significant operation.
Oh, absolutely. It's a bigger deal.
You are creating a secondary surgical site in the abdomen or leg, which drastically changes the recovery timeline and, frankly, the pain profile.
It does. But from a structural standpoint, the native tissue integrates naturally without the risk of plastic eroding through the vaginal wall later on.
And the success rates are good?
The durability is remarkable. With success rates hovering between 80 and 90%, it is particularly effective for complex cases involving ISD.
There's a catch, though, right?
Tensioning, yes. Utilizing native fascia introduces a major variable. Synthetic mesh is uniformly elastic and predictable. A harvested strip of native fascia is not.
It's just a piece of tissue.
Right. It requires more aggressive anchoring and relies on the surgeon's tactile feel of their experience to set the tension just right.
Which explains the significant spike in post-operative urinary retention. I mean, the sources note that patients receiving an autologous sling after a failed mesh sling have an 8.5% rate of urinary retention requiring intermittent self-catheterization.
That's right.
Compared to just 3.1% for a repeat synthetic sling, that's more than double the risk of retention.
Well, the autologous sling is inherently a more obstructive procedure. You are effectively creating a mild, intentional roadblock to overcome the severe incontinence, and occasionally that roadblock functions a little too well.
That makes sense. Now, if the goal is avoiding mesh, another option on the menu is the Birch-Kulpo suspension.
Yes, the birch.
This bypasses the sling concept entirely. Instead of placing a hammock underneath the urethra, the surgeon uses permanent sutures to grab the vaginal tissue beside the urethra and anchors it upward to the Cooper's ligament on the back of the pubic bone.
It achieves excellent elevation and stabilization of the bladder neck, boasting success rates of 85 to 92%.
That's incredibly high.
It is an outstanding anatomical fix, but, and this is a big but, it comes with a strict contraindication based on our earlier diagnostic phase.
It won't work for intrinsic sphincter deficiency.
Exactly.
Because if you anchor the tissue and lift a broken nozzle up to the pubic bone, well, the nozzle is still broken. The birch only treats hypermobility.
The physics simply don't support using a Kulpo suspension for ISD. It stabilizes the hose, but it provides zero circumferential compression to help a weak valve actually close.
Let's look at the patients who absolutely cannot undergo a major revision, like whether due to severe medical comorbidities making anesthesia dangerous, or simply the psychological trauma of a previous surgical failure.
Right. Some patients just need a less invasive path.
The data looks at tape shortening and urethral bulking agents. Let's start with tape shortening.
Tape shortening is a highly niche intervention. Like highly niche.
Why is that?
If the initial mesh sling was placed too loosely and the relapse of incontinence occurs very shortly after the primary surgery, a surgeon can theoretically reopen the vaginal incision, find the existing tape, and suture it tighter.
But the success rate is pretty low, right?
Yeah, only around 40%. Once scar tissue sets in around the loose mesh, tensioning it retroactively is just mechanically inefficient.
Okay, what about urethral bulking agents? Because they seem really counterintuitive for a patient who has already failed a gold standard surgical fix.
I could see why you'd say that.
I mean, injecting hydrogel or collagen directly into the urethral tissues to plump up the sphincter is notoriously temporary. The body eventually absorbs the material. Why utilize a temporary fix for a complex surgical failure?
Because quality of life and patient psychology carry immense clinical weight.
Oh,
If you have a patient whose primary failure left them terrified of pelvic surgery, or someone lacking the physiological reserve to survive a fascia harvest, a 10-minute office-based injection is a lifeline.
even if it wears off.
Even if the bulking agent only provides continence for 9 to 12 months before needing a top-up, it allows that patient to return to normal activities without the compounding trauma of another major pelvic operation.
That's a really fair point. It's not always just about the mechanics, it's about the patient in front of you.
Exactly.
Which brings us to the most delicate aspect of revision surgery, navigating the physical remnants of the first failure.
The excavation phase.
Right. If a patient chooses an autologous sling, specifically because they have voiding dysfunction or pain from the original synthetic mesh, the surgeon has to deal with the existing plastic before they can rebuild.
In removing integrated synthetic mesh, transitions the surgery from a restorative procedure into a highly complex excavation.
Because the original mesh is designed to be permanent, right?
Yes, the pores of the plastic are specifically engineered to encourage the patient's fibrotic tissue to grow through them, anchoring it in place permanently.
It is the ultimate double-edged sword. Like if you picture a thick vine growing through a chain link fence, the vine becomes structural.
That is the perfect way to visualize it.
If a patient is in urinary retention because the mesh is too tight, you could do a partial excision, just trimming the section of the vine that is choking the urethra.
Right.
But if you attempt a complete excision and rip the entire root system of the plastic out of the pelvis, you basically pull the fence down with it.
That visualization aligns perfectly with the clinical outcomes. When a surgeon performs a complete excision of a synthetic sling, they aren't just removing plastic. They are forced to resect the native periurethral tissue that the mesh integrated with.
So they're leaving a huge defect behind.
That essentially leave a denervated, devascularized void. The data shows that complete excision results in a much higher incidence of severe, recurrent stress urinary incontinence compared to a partial excision.
Or a simple erythrolysis, right, where the surgeon merely incises the scar band to release the tension without ripping all the lateral mesh arms out.
Exactly. You are intentionally leaving dormant plastic in the pelvis to preserve the residual structural integrity of the surrounding tissue.
But what happens if the mesh has eroded into the urethra itself? Like, you have to remove it then. You have to cut into the urinary tract to get the plastic out.
You do. And that scenario triggers one of the strictest clinical principles in pelvic reconstruction.
Which is?
A synthetic mesh should never, ever electively be placed in close proximity to a fresh opening in the genitourinary tract.
Because inserting a foreign porous plastic over a fresh surgical wound in the urethra is practically inviting bacterial colonization.
It is an unacceptable risk. The disrupted vascular supply from the incision won't support healthy tissue integration.
Meaning the new mesh will likely erode right back into the exact same spot.
Or worse, create a fistula between the bladder and the vagina.
Wow. So what does the surgeon do in that case?
If the revision requires cutting the urinary tract to remove the old mesh, the surgeon must either utilize the patient's autologous tissue for the immediate repair, or they must stage the procedure.
Stage and like do it in two parts.
Yes. Removing the mesh, waiting several months for the tissue planes to heal and revascularize, and only then going back in to address the incontinence.
That sounds grueling, but necessary. Before we wrap, the clinical data highlighted one highly specialized scenario: adjustable or spiral slings.
Right, a very niche tool.
Where does an adjustable implant fit into a revision strategy?
It addresses a diagnostic finding called detrusor underactivity. Sometimes urodynamics reveal that the bladder muscle itself is incredibly weak.
Okay, and if the detrusor muscle cannot generate enough squeezing force?
Any standard sling you place to stop the stress leak will act like a dam that the weak bladder just cannot push water over.
Oh, so you fix the incontinence but immediately throw the patient into permanent urinary retention because they lack the muscular force to open the newly tightened valve.
Exactly. You trade one problem for a arguably worse one. For a patient with detrusor underactivity, an adjustable sling allows a surgeon to mechanically alter the tension of the mesh post-operatively in the clinic.
So they can dial it in?
Yes, they can dial the tension up or down by mere millimeters, finding the absolute microscopic threshold that stops the cough leak, but still allows the weak bladder muscle to empty.
That is fascinating. The overarching takeaway for you, listening and navigating this space, is that treating a failed midurethral sling requires abandoning the one-size-fits-all mentality entirely.
Entirely.
You have to isolate the precise physiological reason the original support structure failed. Whether the breakdown was caused by mesh erosion, the flattening out of a transobturator angle, or the internal deterioration of the sphincter valve, the subsequent surgical blueprint has to directly counteract that specific mechanical deficit.
It is the ultimate application of anatomical problem solving. But, the complexities of extracting integrated plastics raise a really compelling question about the future of this field.
I'm intrigued. What's the question?
Well, we've detailed how destructive it is to remove synthetic mesh from native tissue and the surgical shift back toward using a patient's autologous fascia for complex revisions.
Right, going back to using our own tissue.
Given the rapid advancements in regenerative medicine, how far away are we from a reality where bioengineered tissues entirely replace synthetic plastics in pelvic floor reconstruction?
Oh, wow. Lab-grown tissue.
Yes.
Yeah.
Imagine eliminating the clinical concept of mesh erosion permanently by utilizing lab-grown biocompatible grafts that perfectly mimic the elasticity of native fascia without the irreversible risks of permanent plastic.
That would completely rewrite the biomechanics of pelvic reconstruction. We wouldn't be trying to excavate plastic from a damaged fence. We would be fundamentally growing a stronger structure.
It's a future worth working toward.
Absolutely. Thank you for joining us on this deep dive into the realities of sling revisions. Keep questioning the mechanics behind the diagnosis, and we will see you next time.